I want to welcome you to our last session of the day, entitled Join the Conversation, Building a More Resilient Healthcare System. After a COVID year, there's so much to say about resiliency. So for this discussion, we're joined by Ross Wallace, a principal at Santis Health. Ross has helped to create and launch the Resilient Healthcare Coalition, a new cross-sector partnerships focused on strengthening Canadian health systems as they emerge from COVID-19. Dr. Brenner, an epidemiologist and data scientist at the University of Calgary. We have Dr. Hanna, a clinician scientist at the Ontario Institute for Cancer Research, and Barry Stein, who you know, President and CEO of Colorectal Cancer Canada. Ross will introduce our session and start by sharing a short video. The panelists will then join Ross and share their perspective on the issue confronted by colorectal cancer patients during COVID, but also how we need to improve the healthcare system in Canada to be ready for the future. We do invite all of you to bring forward your ideas and suggestions and to join in the conversation. You can do so by using the chat or question button at the top right of your screen. We'll end the session by a short Q&A to be able to hear your thoughts, suggestions, and feedback. So Ross, the floor is yours.
Thank you so much, Dominique. It's an absolute pleasure to be here and to moderate this session with three distinguished panelists. As you've heard many times over the course of the last few sessions, and of course throughout the conference, the theme is about engaging, educating, and empowering. And I'm convinced that we'll have an opportunity to accomplish hopefully all three of those goals through this session. I'm also honored to have Barry, to have Tim Hanna, and to have Darren Brenner offer their complementary perspectives on this session. In my mind, what we want to do with and for all of you today is two key goals. The first is to unpack how patients have been impacted over the course of COVID-19 in their treatment and in their experience with the healthcare system, the cancer healthcare systems across the country. Obviously, there have been negative elements, and we'll hear more about those going forward. But perhaps there have been innovations and responses that we need to protect, that we need to expand, and that we need to call out that have occurred in part through the changes in healthcare systems as part of COVID-19 or in response to COVID-19. The second goal is really to explore what still needs to change, what we can do to build back better, if you will, and what are the gaps that still need to be filled, and what are some of your individual ideas on how best to fill those gaps. So we have an unparalleled opportunity to make systems stronger, more robust, and more resilient than they ever have been before, to learn the right lessons from coming out of this pandemic and to better understand the problems we're all working together to try to solve. So with that, I'm going to turn to a brief video that I think powerfully sets the stage for some of the challenges and the opportunity, and then we'll come back to our panelists.
The best chance to beat cancer is to treat the patient when they're at the early stage of disease. You want to get it early and you want to treat it early.
So when COVID hit, cancer screening was interrupted. Because of the interruptions on these screening programs, people will miss their chance for an early diagnosis. They'll find out they have cancer when it's already progressed to a later stage.
Amongst my patients, there have been longer than usual waits to get a diagnosis of cancer, and that means a longer time than usual to get the appropriate evaluation and treatments that they need. It's extremely important for the healthcare system to be ready to deal with the next crisis.
We need to be innovative, collaborative. We will need streamlined solutions with new technologies to be more efficient. Collaboration is going to be key. We all have to work together to get past this and get past the next crisis that's sure to come.
Our preparation needs to begin right now.
So that was indeed a powerful video, and fantastic to have both Tim and Darren as part of this conversation. You'll be hearing from both of them momentarily on some of the ideas that they called out, and really the call to action they articulated about preparing for the next crisis and about collaborating to make that happen. Speaking of collaboration, I think this is a perfect opportunity to pivot to hear from Barry, to talk about the importance of collaboration, to talk about the challenges that we've all gone through, to talk about his vision and Colorectal Cancer Canada's vision for where we go next. So Barry, I'll pass the mic to you.
Thanks, Ross, and thanks, Dominic, for wonderfully introducing this section. Our panel today is about resilience in our healthcare system as it pertains to colorectal cancer patients. And by that, what I mean is a healthcare system that can withstand the impact of a sudden shock such as COVID-19. But actually, it's really much more than that. We've all been impacted by COVID-19. The pandemic produced a shock to our cancer care system that we've never seen before, and we were ill prepared for it. Most of us have been affected personally, and so were our family members. In many cases, we had to undergo visits to our hospital alone, have tests and treatments alone, and sadly, in many cases, many of us died alone. We have had our follow-up appointments with clinicians delayed and turned into virtual visits, sometimes for the better, and sometimes not so good. We've had our tests delayed or canceled. We've had our treatments altered to oral treatments in some cases without fully knowing the impact on our treatment. We've had our surgeries delayed, access to clinical trials suspended, and our colorectal cancer screening programs for the population at large were suspended, the consequences of which will be painful and long-lasting. This was, of course, in part to keep us safe and due to the fact that our healthcare professionals were shifted from cancer care to work on the front line to help patients in emergency with COVID-19. And for that, we thank them greatly. We were, however, unprepared and burdened by a system already under pressure, even before COVID-19. There were already pressures on the system impacting personalized healthcare and access to treatments, surgeries, delays for colonoscopies and other diagnostic tests, and so forth. Our healthcare workers were and are in good faith, and this was not their doing, and the system failed us all, as it could not cope with the sudden impact of a pandemic. Today, Dr. Brenner and Dr. Hanna will tell us about the impact of the pandemic on screening and cancer care, as it is crucially important to understand where we are and what happened. And indeed, they too have ideas of their own on how to bring about change for the better. But it's up to us, as patients and caregivers, to explain the impact of the pandemic that it's had on all of us and to help provide solutions so that our voice as patients and caregivers. Our challenge is to work together with our healthcare providers to ensure not only a more resilient healthcare system, but how to build it back better, not only to withstand the impact of a shock like COVID-19, but to ensure that structural changes are made to strengthen and improve our systems, and in particular, our cancer care. I know it's possible because we have learned and continue to learn so much from this experience, and we see opportunities in areas such as virtual health, better scheduling of appointments, decentralized trials, creating safe corridors for cancer patients to receive their treatments and tests, opportunities to have follow-up care out of hospital cancer centers, sharing of data so that we can act upon it in real time, and many more things that we can do. As I mentioned, as we move forward with our impact on creating a more resilient healthcare system, we need your impact. If you think your input doesn't matter, or that a single voice is too small and can't change the system, just try spending one night alone in your room with a mosquito. It's guaranteed to get your attention. This is just the beginning of our project, and I hope that all of you can provide your input, both on how the pandemic affected your care so that we can learn more and suggest how to improve our healthcare system. So check out our advocacy section on our website at colorectalcancer.com, Canada.com, on Ready for the Next Round. And I look forward to all of you joining the conversations. So now, Ross, back to you, and I look forward to hearing from Drs. Brenner and Hanna.
Great, thanks so much, Barry, and thank you for sort of offering your own perspective on elevating the importance of patient voices, not simply as individuals, but as aggregated and synthesized perspectives. That is how change happens, when voices come together, when ideas are shared and improved and deployed to policymakers and those who have the opportunity to improve systems. I'm going to turn to you first, if I can. Barry spoke about structural challenges and structural changes, the challenges exposed and exacerbated by COVID-19, and the changes required to ensure that what we create afterwards is far better than even what existed before the pandemic. Can you elaborate a little bit on your own perspective around those key challenges and those key changes?
Certainly. And thank you, Ross, for the introduction, and happy to get to this information. So as an epidemiologist, I conduct studies to understand colorectal cancer risk and evaluate the outcomes related to colorectal cancer screening. So when the pandemic struck in Alberta, where I am, and in most provinces in the country, many procedures were stopped completely, including colonoscopies, as well as the delivery of fecal-based screening and testing. So our researchers and clinician colleagues had a pretty clear idea that this interruption would have a pretty meaningful impact on the great progress that's already been made on colorectal cancer control through population-based screening. We wanted to understand exactly what that impact would look like. So to do this across Canada, we partnered with the Canadian Partnership Against Cancer to model this impact of different scenarios of what these interruptions to screening would look like due to COVID-19. So as we started to think about what this sort of main impacts would be, we figured there would be three main impacts on the screening programs. First, there would be a high volume of canceled or of missed appointments through these initial waves of COVID-19. So these appointments would either be missed altogether or would be pushed back and further delayed. Second, upon reopening after these initial waves, the programs could only handle a reduced capacity of colonoscopies or sigmoidoscopies. For example, if a facility could have 10 people in their waiting room before COVID, now with physical distancing restrictions, they could only have 4 or 5, and similarly with the number of procedures to maintain safe procedural practices. And lastly, after this COVID-19 situation subsides, there'll be quite a buildup in the increase in wait times for new people coming into the screening system to handle any built-up demand after these first two impacts on the system are carried through. So we modeled the impacts of these changes through different potential time windows of shutdowns, if you will, or interruptions in our study that's now published in the Journal of Medical Screening. So what we found was that if we have a 6-month delay, like what we've observed through the first two waves, the opportunity for an earlier diagnosis for about 19,000 adenomas or colorectal polyps would have been missed. Of these, about 10,000 would be advanced adenomas that could potentially be clinically relevant and progress into cancers. So over the lifetime of the individuals who would have been affected by these interruptions or missed screenings, this would lead to around 2,200 more colorectal cancer cases, with about 60% of those presenting at an advanced stage of disease, so stage 3 or 4. And taking cumulatively, this adds up to over 30,000 potential years of life impacted due to a 6-month interruption in screening. So these alarming figures suggest that the impact of COVID-19 on colorectal cancer screening are definitely going to be considerable. So no doubt we will have to adapt to meet these challenges, but we're actually already starting to see some solutions and some resilience building up within the system already. So what are we doing now? What are some of these changes? So we're starting to see a shift to fecal-based testing as the primary index test. So away from things like colonoscopy or flexible sigmoidoscopy for an average risk individual, because these require in-person visits and they're very resource and they're clinician intensive. So really moving away from any asymptomatic tests for colorectal cancer screening to prioritize those who have higher risks. We're working on developing data-driven approaches to further identify, further triage those patients who are at highest risk for disease and who would most benefit from colonoscopy. And we're working really hard to come up with better ways to collect and understand the gaps in diagnosis and care through advanced data integration to identify early on where those gaps are going to be and how do we best address, overcome, and catch up. So the positive news from all of this is here in Calgary, when we did reopen our colorectal cancer screening center, we saw a huge surge in patient uptake, patient participation. both within coming for their procedures, but then also the proportion of patients who want to participate in research studies to help us understand gaps and help us identify these best data-driven procedures and pathways. So patients are really keen to help us get the system back on track. We're also seeing a record number in patients who are providing their FIT tests. So really, people are listening to the messaging that it's time to put COVID behind us and it's time to bring cancer screening back to the forefront in public health. And we're also seeing that governments are realizing the value of real-time data collection and data monitoring procedures. So these investments are starting to show up and being made to have more real-time, more detailed data collection and monitoring. So in fact, it may actually be that this COVID-19, while it has presented a pretty considerable impact to the cancer screening system, is what raises this need and this priority for better data monitoring to the forefront. So certainly COVID will have considerable impact on screening, but it seems like these lessons that we learned will definitely improve the system going forward.
Darren, thanks for unpacking both some of the most likely ways in which the COVID-19 delay and impact on patients and their care are going to be felt in the colorectal cancer community. I think we know a lot more about the contours of those challenges than we did a few minutes ago. I really liked the way that you captured and articulated the interest and the engagement you've already seen from patients in contributing to improving a system going forward. I think that's the idea and the inspiration for this entire conference. And I think the fact that you've seen it at the coalface, if you will, is rewarding, but not surprising. Tim, maybe I'll turn to you now if I can, and ask from your perspective, you to just illuminate and elaborate a little bit on some of the particular patient complexities you've seen exacerbated by COVID, and also maybe capture some of that same optimism that Darren shared in terms of outlining your perspectives for the future and ways in which you're seeing some opportunities already to ensure that the systems we build coming out of COVID will be far stronger than the ones we even had going into it.
Thanks, Ross. As you've heard from Barry, the pandemic affected diagnosis and treatment of cancer in Canada. And you heard from Darren how delays in diagnosis can affect outcomes. And I'll discuss how delays in treatment could affect outcomes as well, and what we can learn from this. In our study published in the British Medical Journal, we studied colorectal cancer and 6 other major cancers and looked at the impact of treatment delay on the chance of cure from cancer. We covered the major forms of treatment, surgery, drug therapy, and radiation, and used high-quality information on over 1.2 million people with cancer. We found that delays from diagnosis to treatment impacted survival, or you could say your chance of cure, in most cases. In those cases where we didn't find a clear relationship, there very well could still be a relationship, but more studies are needed. The impact of delay on cure varied between situations that we looked at, but in most cases had an effect of 6 to 12% on mortality. And let me explain what that means. For example, if you had 1,000 people that needed colon surgery, and to put that in perspective, there are around 20,000 Canadians every year that need colon surgery. So if you had 1,000 of these people, you would expect that over the next 5 years, around 350 would die as a result of that colon cancer. If you added an additional 4-week delay, for example, because of COVID-related restrictions and limitations, that 4-week delay in itself could result in 20 additional deaths. And if that delay increased to 8 weeks, that would be an estimated 40 additional deaths. So when you imagine a whole country facing limitations in access to procedures and delays, that can really add up. It's important to emphasize that these effects on mortality are only the tip of the iceberg. When there are delays in treatment, that can affect people's quality of life. it can affect the complexity of treatment. For example, with an early colon cancer, you may only need surgery, but as it gets more advanced to, for example, stage 3, you may also need chemotherapy as part of your treatment. And so with that complexity can come increased toxicity of treatment, and also personal and societal economic impact. For example, more days lost out of the workforce, or with your family. Finally, there can be effects on functional outcomes, or in some cases on cosmesis, or impacts on the way a person looks because of more advanced cancer treatments and the effects on the body. We need to protect those with cancer during the pandemic and beyond, but what can be done? There are short-term rapid responses and also longer-term responses to build the healthcare system back with increased preparedness and resilience. In the short term, at the individual level, it's important to act on symptoms, and we're already seeing that the public is more willing to act and to get on for the pandemic and back to getting screening where it's possible. And I'd really emphasize the importance of staying on track with screening as much as is possible and safe in your region of the country. Where possible, it's important to get vaccinated and to be safe so that access to the healthcare system can be maintained. From a healthcare system perspective, we developed prioritization frameworks to ensure that our resources were used in as just and equitable way as possible when they were limited by pandemic restrictions. And also there were changes in how we deliver care and the content of that care that we've seen as the pandemic has rolled on. There's been all sorts of rapid research in biomedical science, which has been incredible. Vaccinations and their rapid development is one example, and also a lot of really important health services research. There's also been changes in awareness, shifts in values and attitudes that we've faced as we've gone through the pandemic. And for example, an increased awareness of the importance of acting on improving equity, diversity, and inclusion within healthcare and society. What about the future? We can take what we've learned from the pandemic to make our healthcare system stronger and better. We can innovate in all kinds of ways. For example, innovating in how we develop our system and the governance of that system. We need better real-time data in order to respond quickly to challenges, as we've already heard. And we need better communication of risk and communication of how the public can respond in unusual and situations that have not been experienced before by society or patients. There can be innovations in how we deliver care, and again, as well as the content of that care. And maybe we can address some of those specific examples as we go to our panel discussion. Thank you.
Great. Thank you so much, Tim. And thank you, Darren and Barry as well. I mean, to me, there's a lot of optimism and a lot of ideas that were shared in all of the presentations that you just foundationally left us with for the conversation to come. So thank you all. I love the notion of identifying and closing data gaps. I love the notion of leveraging technology in new ways and giving people an opportunity to access healthcare outside the traditional physical settings that they've often accessed it. I think there's real power and opportunity going forward on both those levels. Barry, if I can, maybe I'll just come to you really quickly to sort of put a period at the end of Tim and Darren's sentences, and then we'll open it up to folks to share their own perspectives on the challenges they've experienced over the course of COVID-19 and receiving the care they need, and their ideas and inspiration for what needs to happen next. So Barry, to you, and then to the folks gathered here today with us.
So thanks, Darren and Tim, for excellent presentations. I have to say that I was thinking about the whole time about what was going on during COVID, but in the back of my mind was, where were we before COVID? We look at screening rates, across the country, population-based screening rates with the FIT programs, and we see that we're at something like only in 3 provinces that have attained at least 60%, which is the target for the population between 50 and 74. So as we think about what we can do to address the problems from COVID, just using screening as one example, because we know if we can prevent the disease, it's a lot easier than having to. Sorry about that. It's a lot easier than having to treat it afterwards. So those are the types of thoughts that come to my mind. And I was wondering, from your perspective, and we can talk about surgery or other treatments, radiation treatment, and so forth. Their levels before COVID. Do you think we can change, whether it's through the use of data or through some changes because of COVID, that would improve not only our ability to be more resilient through a shock like COVID or any pandemic, but also to build back better? How can we ensure that what we do actually not only helps make us more resilient, but improves our situation from where we were before COVID? So with that, Ross, I think that's sort of like a question that I'm putting to Darren and to Tim, and maybe either one can jump in at any time. We'll start with
Sure.
Tim. You look ready.
Yeah, I'm happy to chat. I mean, this is a golden opportunity where there's a lot of discussion and willingness and awareness about the holes in our system that exist right now, the inequities that have always existed but have been really highlighted by what we've seen during the pandemic, and also I think an interest up to high levels in having more coordinated health data, with silos being broken down within jurisdictions and even between jurisdictions, so that we can understand how to respond to our new challenges. Because the next challenge is not going to be COVID. It'll be something that we can't quite predict. I think.
I actually love that idea because one of the problems that we have in Canada, from outside of Canada, everybody thinks we have one healthcare system, but with our 10 provinces and territories, we have to really communicate better if we're going to bring down overall mortality rates, I think, and even whether it's screening or other things like molecular profiling and so forth. We need some national strategies, I think. So I agree with that communication comment.
Maybe I might just add to your sort of question, Barry, about how can we use data to improve the situation. So we can really only know there's a problem if we can see there's a problem. So we need better monitoring and better data to do that. And those rates that you just provided for us, for example, are examples of summary aggregate provincial level data. What would be even more helpful is more granularity. So we know that screening, for example, is not equitable across the population. So we know that there are some groups where it's 65 and 70%, but we know that in some groups where it's much, much lower at 30, 40%. So, investing in efforts to bring those rates up higher in those potentially populations with lower levels of socioeconomic status or higher levels of depravity in certain indices would probably have a greater return on the investment to get that population level up than to go from a group where it's already 70% to 72 or 73%. So I think we need data to even identify those gaps and those inequities. So I think it's something we can definitely take forward.
And I think that applies not only to screening, but I think we can probably say that might apply to treatment. Is everybody getting equitable treatment? Certainly not everybody is getting the same treatment across the country, that's for sure. That we know already because the provincial reimbursement guidelines. But, can that data, gathering of that data, actually help us to provide more equity in our treatments, whether it's the actual chemotherapies or whether it's the surgery or radiation and so forth, right across the country?
Yeah, agreed.
I think
there's a lot of opportunities to gain in shortening waiting times for surgery, and I think what we've learned from our research is that even short delays can impact treatment outcomes. I think we've seen discussion about collaborating across the whole system. So for example, in Ontario, we've seen patients transferred who are critically ill from the Toronto and surrounding area, Brampton, to other regions of the province that have more resources. And I know with cancer, we're not talking about the same sort of immediate emergency when someone's waiting for a cancer surgery, but still these waits matter tremendously. And we need to think about how to harness these resources that are present across the province, for example, through more integrated waiting times. So you're not just as a patient exposed to the wait of one particular physician, though, if another person on the waiting list has a shorter waiting list, then you could get shunted over and get your treatment more quickly.
And I might add that one of the primary factors that drives inequity in access is geography. And so we know that there's been a lot of problems with trying to keep people outside of sort of congested major care centers. And so if we're able to decentralize some of these procedures, it might be very helpful. And one of the ways we can do that is track benchmarks of performance for things like screening endoscopy in family clinics in more rural areas. But in order to do that, we need to have better data to suggest that a certain level of quality is going to meet certain clinical thresholds for population-based screening programs. And that would then, in turn, increase the uptake of these decentralized screening procedures through tracking and data.
And absolutely, it is a priority of our program Ready for the Next Round to work on that collection of data so that we can react in real time.
And so at this point, gentlemen, I wonder... Oh, sorry, Tim.
I was just going to say, I think collecting the kind of granular information on patient and person characteristics is going to be important going forward, so that we understand, what factors are contributing to regional variation. So are there particular groups of people, immigrant populations, other groups where care may not be as equitable, so that we can target messages to reach out to these groups so that their care can be streamlined and improved.
For sure.
So perhaps with that, gentlemen, maybe what we'll do is pass the microphone back to Dominique, who will open the door for an opportunity to hear from some of the individuals who are gathered here today for this colorectal cancer community conference to share their ideas, their inspiration, and their challenges that they've experienced over the last few months. So Dominique, back to you, please.
Thank you all so much for sharing this positive outlook and solutions learning from COVID-19 impact on our healthcare system, and especially empowering the patient voice. So now let's turn to the audience to hear their feedback and questions. That might be the last session of the day, but we have questions coming and people are still really engaged in the conference. That's great. So maybe a first question for you all. Do you feel that it's coming? Do you feel that the investment in early detection, meaning like the general family medical care levels, is too low compared to the investment that Canada makes in the post-diagnostic care?
That sounds one for an epidemiologist to me.
Yeah,
certainly.
Dr. Brenner, do you want to answer this one?
Certainly, that's a great question. And I would say absolutely the investment. We've done some work looking at the return on investment for some preventive programs, some family health programs, and some screening uptake incentivization. And it seems to be highly cost effective in terms of reducing the subsequent treatment cost in the long term. So I would strongly advocate for increased investment in primary prevention activities, not only because they're cost effective, but they also seem to have a wide benefit across multiple health domains, not just for colorectal cancer, but it seems like many of the practices and behaviors tend to be beneficial for a broad number of cancer sites, as well as for other circulatory and cardiovascular disease conditions. So absolutely, I would advocate more strongly for additional investment in primary prevention.
Any additional comments on what was said?
I'm just wondering where the investment is going to come from. And that, I think, is a really interesting question, because we always talk about the importance of primary prevention, and it's always top on everybody's agenda. When it comes to investing, actually putting dollars into this, that's where the big question really is, because budgets come into play, which generally go in cycles, which are hard to change midstream. But I do think, as a consequence of COVID, this might be an opportune time. I think that investment likely will have to come from partnerships that are both public and private partnerships, and I would like to see that grow. And that might be an opportunity for the federal government to get engaged with industry and academia in order to advance this type of investment. In addition, I think we're talking what Dr. Brenner was referring to before, the inclusion of data, and actually Dr. Hanna as well. If we don't have the data, it's very hard to make these decisions in order to avoid a consequence. And that's exactly what we have to do to create a more resilient healthcare system, I think.
Thank you, Barry.
Perhaps Ross or Tim, you want to add to that?
Tim?
Well, I guess only to say, and this is only one part to determine cost effectiveness, but when you think about the incredible costs for systemic therapy for advanced and often incurable cancers, it really puts into perspective the amazing return on investment in catching cancer early and preventing cancer.
Great. Ross, anything to add before we move to the next question?
No, I think Tim put a really nice period at the end of the sentence, so let's take the next one.
That's great. So in the discussion, in the panel discussion, we talked a little bit about screening. So there's a question here in terms of how and what about the patient that aren't at high risk, particularly like the one that early age onset population, since colonoscopies are even less accessible. So how can we really look at asymptomatic patients who are considered low risk and ensure they get screened?
I'll try that one. And I know that Darren's done some modeling on this as well. It's very coincidental that today the United States Preventative Task Force just came out with new guidelines lowering the screening age to 45 in the United States. That wouldn't have helped me because I was 40 when I was diagnosed with metastatic disease, but it definitely does belie the trend that's going on right now. We do see younger, as evidenced by our panel today, with 22-year-olds diagnosed with advanced disease. I mean, it's shocking. It's a whole new generation of patients who have to deal with different types of consequences at such a young age. So we really need to look at this in Canada. I know it's been the system has been rather resistant to lowering the screen age, but I think that as we see this around the world, as the screening age lowers in the United States, I think the pressure is going to be on us in Canada to do likewise. Perhaps not immediately. Maybe we'll watch what's going on in the United States first. But that is all the more important for us to not only engage younger individuals who may have signs or symptoms of the disease, to engage with the family practitioners in order not to turn away patients. And that may even be more important because, guidelines are guidelines. They start at 45, but cancer doesn't know guidelines itself. Yeah. So I think we really have to take a look or relook on a continual basis as to what we're doing about early age onset.
Is there a role also in education of this?
Some of the modeling.
Sorry, go ahead, Barry.
Go ahead, Dominic.
I was just asking, like, as I'm listening to Barry mentioning and all that we heard today about the younger population facing colorectal cancer and this diagnostic, like any education that we can kind of do in terms of raising that awareness to be able to have that these patients being screened a little bit more.
Yeah, I might just sort of echo a bit what Barry mentioned in terms of sort of symptom awareness, and Colorectal Cancer Canada, a fantastic survey of patients that asked about sort of what did their journey to diagnosis look like for those early onset patients, and the predominance of cases, there was sort of a persistent pattern of symptoms that, with eventual advocacy on their own behalf, they were able to get diagnosis and care. So, I think it's going to take some multidisciplinary studies, which we're starting to do with some of the gastroenterology community and the sort of central triage care for when we see patients younger who have sort of persistent GI symptoms that might be indicative of an underlying disease, to sort of work with family physicians and also the specialists in that domain, sort of outside of the cancer care community, to acknowledge and start having some red flag symptoms to sort of try to trigger for those populations where, as Barry mentioned, there has not been a quick jump to move the screening age to 45 or 40 or sort of have that sort of increase in the screening population here in Canada. So I think it's going to take some multidisciplinary work, which is starting to happen, and that seems to be the case of these sort of symptom-based or symptom-derived prioritization of patients in that age group.
Okay, thank you, Dr. Brenner. Dr. Hanna, anything to add to this discussion?
Yeah, so I think that, reflecting on what's been happening during COVID, we've seen that, cancer presents in a lot of different ways, and not everyone will have a guideline supported screening indication. They might have a vague symptom and not be able to access their family practitioner, or the family practitioner may have a concern but not able to access the specialist. And I think it speaks to the very intricate safety net that we have built into our system and how each part is incredibly important, and sometimes not in ways that we expected. And I think COVID's really shown us that. So I think it speaks to the need to have really solid access to care for all of those people that aren't presenting in the normal ways.
Yeah, thank you. Especially with COVID, that's impacted. Go ahead, Barry.
Just wondering, we know from some of the articles published that one of the fastest growing cohorts is between 28 and 39-year-olds with rectal cancer in particular. And as a radiation oncologist, I'm wondering if you're seeing that uptake in Kingston as well.
We have seen some young cases. I don't personally treat rectal cancer, but as a group, I'd say that we have seen more than before.
Another question from the audience. How far away is Canada and the provinces from using the ctDNA analysis and for diagnostic and surveillance?
Well, there is a company, Connexia, who is actually funded by a grant right now doing ctDNA for advanced cancers. So somewhat a little bit different from what's going on in the United States for early stage cancers. I think that this is definitely in the cards. How far away, it's hard to say, but it's definitely gaining popularity, both in the United States and in Canada. And we're also adding different biomarkers, into these tests. We see them being added, so they'll have extended use, for different purposes. But I think it will be. It's ongoing right now, so I think it's something that's evolving. It's not something that we're going to pull a switch and then all of a sudden you're going to see it starting. I think we're going to see an evolution in this area. And, as part of our work in molecular profiling in Canada, and the Beat Cancer Coalition, our Get Personal program, seeing how different provincial governments are really taking a strong look at increasing access to different ways to profile patients, both for treatment and for diagnostic purposes. I think we're closer than ever before, and I've never seen it so intense actually in Canada as this past year. And I think we'll look to both British Columbia, where Connexia is, and to Ontario, where I think we're going to start to see some changes in guidelines, and where we'll see not only next generation sequencing, but the use of ctDNA.
So I hear a lot of evolution going in that direction. Anything to contribute to this this discussion in terms of topics? Dr. Brenner?
I might just add that so while it's not in the immediate future, there are also many other similar types of screening tests that are being evaluated. So within the circulation, so either whether it's low traces of a circulating tumor DNA or changes from things like microRNA profiles which are reflective of the changes in the colorectal lining that are sort of predisposed to cancer. So there's lots of action and activity in the research community there, and there's lots of investment from both public and private areas to sort of move that research along. So I think there's lots of promise. It's just going to take a little bit longer until it comes into the mainstream, but I think we will see that in the medium future.
Okay, thank you.
Absolutely. The clinical trials are ongoing, actually, right now.
I think we'll see a lot of increased appetite in this area too, just because a blood test is so much easier to access than say a colonoscopy.
Oh, for sure.
Yeah.
That's for sure. But the drugs aren't.
Repeat that, Barry.
The sedatives aren't quite as good.
There's research also showing that COVID certainly has impacted and disrupted the healthcare so much that, again, the discussion today of how can we build healthcare more resilience is certainly a great one. Maybe to have also your perspective before we move on and close the session. Any plans? So how do you plan to collect? Because I know there's a little bit of feedback on the chat, but how do you plan to collect the suggestion, the solution to really kind of contribute to what you're doing and this building back and building stronger and using and leveraging what we've learned from COVID to build a more resilient healthcare? Maybe Ross, to start with you.
Yeah, thank you, Dominique. I think it's a fantastic question, and all too often we have a challenge in government where those who are responsible for accelerating access to new innovations and technologies are different from the folks who are responsible for managing healthcare costs. And as we've talked about through today, and as many individual patients and system leaders understand, there's not always a natural or optimal alignment between those two worlds. And I think if we individually and collectively can figure out how to speak the same languages and the same messages to both sides of that equation, to ensure that those who are investing in innovations and technologies are also aligned and also connected to those who are responsible for ensuring that those technologies get into the hands of individual patients, and to move upstream, as we've talked about through this conversation, to ensure that that we can actually treat people earlier and ideally in both an efficient way and a cost-effective way. I think there's real power that comes in delivering those same messages to multiple receptors. So that's one of the things Barry and I get the good fortune of working on together, and hopefully it's something that we can loop Tim and Darren into as well, and many of the other people on this conference. Yeah,
I think there's a great opportunity. So maybe let's have all your perspective on this. Like Dr. Hanna, any perspective in terms of how you can collect and get more solution and suggestion into building more resiliency?
Yeah, I think a lot of it comes down to collaboration and communication, getting together, and as we're doing now, sharing ideas and trying to understand the different perspectives on the topic. I think that we'll need to have future meetings, and I know that Barry already has this in mind. And I think there are a lot of different groups represented here today, and I think each of us in our own spheres of influence can take this discussion forward and keep asking the questions that we're asking now to make sure that we don't lose this momentum and we do actually change the system.
Thank you. Thank you, Dr. Hanna. Dr. Brenner, anything to add to that collection of suggestion and how you can really kind of gather all the voices around the table for this topic?
Yeah, I would just make a pause to say the interruption of all of the work we do in screening and treatment actually has shown that what we were doing was working. It was making a difference, making an impact. So it actually sort of provides an even more teachable moment to say to the system and to say to those sort of decision makers that we can do this, we can make an impact, so let's build back better. Let's take this moment to make changes where we can. So even incremental pieces of change can make a big impact in terms of patient lives and the future. So I think those kinds of discussions are happening right now, and I think because it's such a big problem, people are amenable to big solutions right now. So there are multidisciplinary discussions that are happening. There are these types of interfaces that are occurring for the first time right now, which I think is exciting, and I think it will facilitate coming back to where we were in terms of making a difference and carrying it even further.
Thank you, Dr. Brenner. But Barry, I know this is dear to your heart. Is there anything to add from also the perspective of the patient and the association in terms of contribution?
Well, absolutely. First of all, I really have to thank Dr. Brenner and Hanna and Ross for not only today's session, but for their ongoing work in this area. This is not something that happens in one session, won't even happen in 1 year. It's something that we have to build together. And what's been so amazing is everybody's willingness to incorporate the patient perspective. And we really need that better, because after all, it's the patients who are impacted by COVID. It's our cancer care that was interrupted, suspended, changed, and so forth. There are some great learnings, not just virtual health. There are many other ways to build back better at every level of our system. So we need the patient caregivers. We need everybody's, not health professionals, of course, academia, statisticians, epidemiologists, oncologists, surgeons, rad-oncs, everybody to contribute to this rare opportunity where there will be a willingness. You can join the conversation by sending us at Colorectal Cancer Canada your ideas, solutions, suggestions. We are going to be holding a further meeting this summer and incorporating some new ideas, following along as well with the Resilient Healthcare Coalition that Ross is leading, and working together with Kingston, Calgary, and other academia. And hopefully we'll get our politicians involved at the same time if we're going to make a change, and maybe raise this as a platform issue for the upcoming election.
On that comment, Barry, I want to thank you all for a great session and sharing such important information to hopefully enhance our healthcare system and learn from the year that we've just had for a better future. I think the message has been launched in terms of join the conversation and have a voice at the table. So I think we'll now proceed to closing remarks. And again, thank you to all of you for this great session.
Thank you all.
Thank you, Dominique.
Thank you.
Thank you.
So we hope you enjoyed the day. We hope you met new people, you learned and felt part of this great community. I certainly did. After a day like this, I'm looking forward to tomorrow. Today was certainly inspiring and filled with great content to engage, to educate and empower everyone, from sharing and learning from patients, caregivers and family members, to the impact, but also the discussion on treatment plans and healthcare resiliency. So certainly covered a lot of very important topic. Barry, I'm going to leave you the the last words, and would love to have your impression on today's.
Sure. Well, thanks so much, Dominique. I mean, you really did an amazing job of coordinating everything together, along with all our staff and, of course, the technical people behind all of this today. It was certainly a new experience, and I hope that people had the opportunity to go to the virtual lobby and to the exhibition hall and see the exhibits there, and even to take a photo in our photo booth. And you can take as many tries as you want for the right photo there, which will be available for everybody after the conference. So I have to say, I was so impacted by so many of the sessions, hearing the stories of self-advocacy in our first session, going on with the most heart-rending stories on emotional impact of colorectal cancer with Mary Jane Esplin, and Samantha, who really touched all of our hearts. That's for sure. My only sort of regret is that I couldn't be in all of the Choose Your Journey sessions. I did flip around from to all of them just to get a taste. But next time I'll definitely be reviewing the films on these, and so will the audience have this opportunity after the conference to really understand what what went on in Dr. Hauser's session on incorporating integrated medicine in your treatment plan. The caregiver perspective, so beautifully put, and a great panel with Enrico and Matthew Ross, who really know firsthand what it is to be a caregiver. And then, of course, on personalizing your treatment with Dr. Boutros and her great panel with Dr. Loisel and Elliot Goldberg and the rest of them, fantastic. But I think for me, what really touched home as being an early age onset patient was that amazing session that Dr. Mary DeVera gave with a panel who was just blew me away. I have to say, I had a lump in my throat the whole time, and still do from that. And finally, thank you to Tim and to Ross and to Darren for this last panel. I know it went quite long, from the sort of individualization of everything and those real personal stories that we heard before, to system building. We promise we won't do too much of that, but you have to remember in the future, if we want to have great care, we really have to build back better. So with that, I want to thank once again our sponsors for the event, who are in the virtual lobby. You can see them, and some great films when you click on them, as well as our own booth there, and those in the exhibition hall. And thank everybody. I look forward to seeing you all tomorrow.
Thank you all. Have a great evening, and we hope to see you all tomorrow.
Thank you.